First of all, I want to thank Jean-Pierre and Mark for their kind invitation. I'm really honored to be here presenting today. I also want to thank the staff, Cecilia and all the staff who worked with Jean-Pierre that were extremely helpful in making this trip happen. This morning, we already heard Mary Jean. She presented some of her data about methadone and buprenorphine. So I'm going to expand a little bit more on the use of medications to treat both the concurrent addiction to opiate and cocaine. So I'm going to start, what is the, just to next, to show the slides, Jean-Pierre. Go to the next slide. Oh, maybe it's this one? Yeah. So the use of opiates and cocaine is commonly known in the streets as speedball. Speedball is a combination of these two substances, and substance abusers combine them to boost the effects of each one of them. So the combination is highly addictive, and people say that they feel better and they have a greater level of euphoria. But unfortunately, this combination of drugs causes more medical and psychosocial complications. And as it could be very easily concluded, it can be very difficult to treat. So the treatment of the comorbidity is quite challenging. I'm going to describe basically the different treatments that are provided and have been investigated for this comorbidity. Just as a matter of introduction, first present some of the prevalence of substance use disorders using the DSM-4 criteria. And this is in the United States, according to the National Survey on Drug Use and Health from 2009. There are approximately 1.1 million cocaine people who meet criteria for cocaine use disorders, and of them, about 192,000 report to have a substance use disorder to an opiate analgesic, and about 121,000 are also have a heroin use disorder. Conversely, there are approximately 409,000 people with heroin use disorders, and of them, about 122,000 have a cocaine use disorder. So you can see as now is a big problem. Now, if we move to the prescription opioid disorder, which is the new epidemic in the United States, there are approximately 1.8 million people who meet criteria for prescription opioid use disorder, and of them, about 192,000, about 10%, have meet criteria for cocaine dependence. So we, according to these numbers, I don't have the exact number of people who meet criteria for the three of them, but we could estimate that the prevalence or the number of people who meet criteria for cocaine plus any opiate, heroin or prescription opiate abuse, could be around 200,000 people approximately in the United States. So it's in terms of treatment, is a big population that needs treatment. This is the number of individuals who received treatment in the past year in the United States. Most individuals received treatment for alcohol, as expected. The next one was for marijuana. About 1 million people received treatment for marijuana. And now the next one is for pain relievers, 754,000. Followed by cocaine, which is about 700,000 people, and then heroin, 417,000 people. So if we look at the statistics, those are analyses that I did using the National Survey on Drug Use and Health. If we look at the last and current treatment for substance use, there are approximately 795 people who received treatment for cocaine dependence, and 44% of them had an opiate analgesic problem and 42% a heroin problem. About 520,000 people saw treatment for heroin dependence, and 65% of them had a cocaine problem, so it's extremely high. And prescription opioid disorder, about 46% have a cocaine problem. So we are talking about 50% of, more than 50% of individuals with an opioid use disorder have also a cocaine problem. Those are the medications that have been, multiple medications that have been tested for the treatment of cocaine dependence. And the list is 50 or more medications. I'm listing here the ones that have shown some early efficacy or that went through a phase 2B or phase 3 type of clinical trial, including baclofen, modafinil, topiramate, disulfiram. Those 4 medications, there have been studies, but there are no conclusive results about their safety and efficacy for cocaine dependence. Right now, there are large double-blind studies being conducted with vigabatrin, is a GABA agonist, with citalopram, is the serotonin reuptake inhibitor, and with the cocaine vaccine. But again, we don't have conclusive results. Hopefully, we will have some results in the near future. Treatment for opioid use disorders, Mary Jean and Herb already presented some of the medications that have been used for these disorders. We all know the agonist methadone or LAM, antagonists like naloxone and naltrexone, the partial agonist buprenorphine, and the partial agonist with the antagonist buprenorphine naloxone, and symptomatic treatments that are being tested right now with lofexidine and clonidine, although the last 2 medications have not been approved by the FDA for the treatment of opioid use disorders. So if we keep in mind that the 2 groups of medications that have been tested for cocaine and for opioid use disorders, these are some of the potential strategies or some of the strategies that have been tested for the codependence of opioids and cocaine use disorders. So one is the mu agonist, kappa antagonist, nalbuphine, opioid antagonist like naltrexone, the partial agonist buprenorphine, opioid agonist methadone, and other medications like amantadine, lofexidine, and there are others. So I'm going to start with nalbuphine. Nalbuphine is a kappa agonist, a partial mu antagonist analgesic. It has a very low abuse liability. It has a very long duration of action, IM, IV, or subcutaneous. And in animals and rhesus monkeys, it has shown to reduce cocaine self-administration without altering food maintain responding. Also, there is some dose-dependent downward shift in the cocaine self-administration dose effect curve. And the problem is that it may precipitate opioid withdrawal. So it has not, as far as I know, it has not been tested in humans for the treatment of this comorbidity, but eventually, given the pharmacological characteristics, it could be a possible treatment, but like I said, it has not been tested. The other alternative could be naltrexone. Naltrexone is an opioid antagonist, and this is a study that was conducted by Joe Smith in Texas, showing that naltrexone 50 milligrams and relapse prevention therapy show fewer cocaine-positive urines than in any other condition. So we have here different weeks of treatment. This is the group that received the relapse prevention plus naltrexone, and you can see the longer the treatment, the more the difference with the other groups. So the study was conducted with oral naltrexone. It has not been done with depot naltrexone, with Vivitrol, the new presentation or formulation of naltrexone. So hopefully it will be ideal to try to replicate those studies and look at naltrexone for the treatment of the comorbidity, especially in people who are already detoxified. So perhaps people who have received detoxification with methadone or with buprenorphine, and give them naltrexone to see if depot naltrexone to try to treat their remaining cocaine dependence. Now, naltrexone this morning also was mentioned that it's being tested for the treatment of other stimulants, especially for amphetamine and methamphetamine dependence. So this could be a very good candidate for a very nice study to look at for the comorbidity. Unfortunately, also, there is very little research about the transition from opioid agonist to antagonist. And as you know, if someone who is receiving opioid agonist, methadone or buprenorphine, or is using heroin on the street and is treated with naltrexone, you can precipitate a very severe withdrawal. So before administering naltrexone, is required to have a naloxone challenge or some way to demonstrate that the person is not sufficiently addicted to opiates to precipitate opiate withdrawal. Now, the next one is buprenorphine, and thank you, Mary Jean, this morning. You already gave the conclusions of the study, but I was tempted to go surfing because Mary Jean already covered what I was going to present, but I'm going to discuss it anyway. Buprenorphine is already mentioned today. That is a partial mu opioid receptor agonist with a weak delta receptor agonist effect. It was also mentioned that activates the ORL1 receptor and is marketed worldwide as an analgesic and is approved in the U.S. and in increasing number of countries for the treatment of heroin dependence. Well, this buprenorphine is a medication that pharmacologically is extremely interesting, and therapeutically is also very interesting. So there's a group at Harvard that has been very active in looking at buprenorphine for the treatment of concurrent opiate and cocaine dependence. And I know that this is a very busy slide, but I just wanted to show you the number of studies that have demonstrated, this is preclinical studies in animals, demonstrating that buprenorphine can reduce self-administration in monkeys, that blocks the cocaine-induced place preference in monkeys, that suppresses behavior reinforced by smoke cocaine, and lots of very different studies. So there's a very large evidence in animals that buprenorphine can be a very good candidate for this indication. There are also, like everything in science, we always have positive and we have negative studies, but as you can see, the contrast with the very few negative studies or studies that say that buprenorphine is not effective. In any case, clinical investigators have been very interested in the possibility of using buprenorphine for the treatment of speedball dependence, if we call it with the street name. And there are several human studies. One of them was conducted in Dr. Cleaver's group by Richard Fulton, in showing that buprenorphine decreased cocaine self-administration in humans at doses between 16 and 32 milligrams, and also that sublingually suppressed acute cocaine-induced stimulation of ACTH and euphoria, and that reverses the P300 amplitude in following detoxification. So there's an increasing, there's some, this is based on human lab studies. There's one study showing that at 2 milligrams, which is, we already know is a very low dose, didn't produce any effect and apparently increased the cocaine-induced pleasure effect. And as we remember what Mary Jean mentioned this morning, at 2 milligrams, probably buprenorphine may have a kappa agonist effect, or at least it may wake up the kappa agonist effects that were dormant when buprenorphine was being administered. So in terms of clinical studies, there have been a number of open-label studies. One was conducted by Tom Costin in 1989, showing that cocaine abuse was 5 to 8 times lower than with methadone treatment in people who were treated with buprenorphine. This study is very interesting because I just found out this morning that perhaps as a result of this study and also the next study also published by Tom Costin showing a larger reduction in cocaine use at a dose of 6 and 2 milligrams daily. Apparently, there's one country in the world, I didn't know this, that where buprenorphine is approved for the treatment of cocaine dependence based on those results, and that apparently was also the second country in the world that got approval for buprenorphine, and that's Argentina. I didn't know. It's very, very interesting. So there have been some also studies looking at different doses of buprenorphine, 4, 8, and 12, and 16 milligrams for 21 days, and they had less robust impact on cocaine use than heroin, although higher doses and longer time led to attenuated cocaine use. So we keep going back to this issue about the dose that is being used, and that's very important to keep in mind, because at a higher dose, perhaps the effect is better for cocaine dependence. In 2004, I published a study looking at 4 doses of buprenorphine, 2, 8, and 16 milligrams daily, and 16 milligrams every other day for the treatment of specifically speedball dependence, opiate and cocaine dependence. This was a double-blind, placebo-controlled, randomized. It was a very, in my opinion, very well-conducted study, although it was the PI, so I have to give good publicity to my study. But this is the main result of the study, and it shows very clearly, those are the different groups that received treatment. This is the group that received 60 milligrams every other day, 8 milligrams and 2 milligrams, and this is the group that received 16 milligrams every day. This group showed a dramatic decrease in cocaine use. This is people who were dependent on both. They have to meet criteria for both. And as far as I know, this is probably one of the strongest signals in any cocaine pharmacotherapy study that's showing that it's so efficacious. So with that dose of 16 milligrams a day, apparently buprenorphine can produce a significant reduction in cocaine use. Now, this result was presented at CPDD, and then after that presentation, it got some people interested, and I'm going to come back to this result because I want to, after this, there has been some other research. But before I do that, I want to mention that there have been also some inconclusive studies. There's one study from Eric Strain at Johns Hopkins showing that there was not comparing buprenorphine and methadone, and apparently at a dose of 11.2 milligrams, buprenorphine was not better than methadone. There was another study by the same group, by Eric Strain at Johns Hopkins, and that the doses were lower and there were no significant differences in the groups. And there was another study by either in 1998 that buprenorphine group treated at 8 milligrams provided a greater proportion of negative urine samples, in particular cocaine negative samples compared with the methadone group, although it was not statistically significant. So those studies were not really very conclusive. The first 2 studies were more like secondary analysis, and there was no clear signal from those studies. Now, there have been also studies that showing evidence against buprenorphine. One was by Richard Schottenfeld from Yale, published in 1997. He looked at buprenorphine at 12 and 4 milligrams versus methadone, 65 or 20 milligrams for 24 weeks, and this study did not support the superiority of buprenorphine compared to placebo for reducing cocaine use. There was another study that was published later in 2005, looking at buprenorphine 12 to 16 milligrams or methadone 65 to 85 milligrams, and adding contingency management. And we're going to have a presentation later at this symposium on contingency management to improve retention and to improve the compliance with pharmacotherapy. The study was conducted for 24 weeks. And methadone may be, in this study, they found that methadone may be superior to buprenorphine for the treatment of concurrent opiate and cocaine dependence, and that combining methadone or buprenorphine with contingency management may improve the treatment outcome. So the effect of contingency management is very strong, and perhaps the strong effect of contingency management overshadow any possible differences between the groups. That's one possibility to explain why the results were not as strong as in the study that I published, in which we didn't provide contingency management. It was just straightforward counseling and interpersonal behavioral therapy. Now, this is the result from Schottenfeld. I don't want to say that methadone is not effective. It's just the differences between the groups, and the evidence on buprenorphine may be stronger than the evidence in favor of methadone. Those are the results, and the groups in red were the groups that received contingency management. The groups in green didn't receive the groups in red was methadone plus performance feedback. This is the cumulative proportion of subjects remaining in treatment. And this is the groups in green were performance feedback, and the solid bars were contingency management, and the dashed bars were performance feedback. So there was basically not significant differences. Now, secondary analysis. Several investigators have been interested in looking, after they complete the study, at the effect of buprenorphine for cocaine dependence. And you can see the list of secondary analyses. Perhaps the most relevant one is this study by Paul Fodella and Peter Bridge, published in 2003, using data from a very large multi-site study looking at buprenorphine for heroin dependence, but they look at the use of cocaine, and you can see that over time there was an increase. This is all people were treated with buprenorphine, but there was an increase in the percent of urine negatives for cocaine. The results are not very supportive, but still they go in the right direction. Now, going back to buprenorphine, Gilberto Guerra, who works in Italy, has been very interested in this idea of buprenorphine for cocaine dependence, and he came up with a very clever idea in trying to combine buprenorphine plus naltrexone, trying to block the potential addictive effects and potential negative effects of buprenorphine, and being able to give it to people who are not opiate dependent, and at the same time or people who are opiate dependent that could be detoxified and can be treated with the combination of buprenorphine and naltrexone. You can see the result. This is an open-label study, and we open-label studies, we have to take them with a grain of salt, but in this case, there were very significant difference between the groups. The rates of positive urines for cocaine in the group treated with naltrexone alone, and the group treated with naltrexone plus buprenorphine at weeks 1, 4, and 12 were at weeks 4 and 12 were very significant. So based on that study, the NIDA, the National Institute on Drug Abuse, became very interested in the results of the study that I mentioned before that I published, and the study that Gilberto Guerra published, and then reviews looking at the effects of buprenorphine. And right now, there's a lot of interest in looking at naltrexone plus buprenorphine because it provides a kappa opioid receptor antagonist with an ORL1 agonist activity. So this is kind of like the algebra formula for this multiple receptor activity. So at the end, the idea is to improve the kappa antagonist effect. And NIDA is being conducted, in Rhys-Jones at UCSF is conducting a study looking at buprenorphine plus naltrexone in people who have experience with opiates, and they are giving naltrexone as buprenorphine plus naltrexone. As you know, ethically, you cannot give buprenorphine to people who have not had opiate experience, because it's exposing an opiate-naive individual to an opiate that will be unethical. So, but at the same time, there is a lot of interest in the effect of buprenorphine on cocaine dependence. So NIDA has been funding those studies, looking at the combination of buprenorphine and naltrexone, trying to see if there is a possibility of giving buprenorphine to people and give them naltrexone to prevent the opiate addiction associated with buprenorphine. These are results that have not been published, and those are preliminary results looking at the visual analog scale of liking, the visual analog scale of high, good effect, drug effects, and so on. And until now, the results have shown that the combination of buprenorphine and naltrexone is well tolerated. There are no safety issues, no statistically significant differences between placebo and buprenorphine dose on any measure, no convincing trends toward unblocked buprenorphine effects on any measure. Nobody liked buprenorphine, so apparently the naltrexone effect is enough to block the liking of buprenorphine. No PK interactions were evident, and the main conclusion of this study is the outpatient administration of buprenorphine at 8 milligrams plus naltrexone at 50 milligrams is something that is feasible. So there's a lot of interest, like I said, with the possibility of buprenorphine plus naltrexone for cocaine dependence, especially in people who have been detoxified from opiates. This is the general design of a study that is being planned at NIDA, looking at buprenorphine plus naltrexone. It's called the CURB study, to be conducted in the NIDA Clinical Trials Network in a sample of 300 subjects, looking at this combination of the two medications. So just to conclude, concurrent opiate and cocaine dependence is a significant public health problem and very difficult to treat. Probably 200,000 or more people are in need of some type of treatment for this comorbidity. There's no conclusive evidence of any medication so far. However, buprenorphine appears promising. There's less evidence with methadone, and Mary Jean was telling me that she has some data in animal studies looking at methadone for cocaine, which is something that it will be very interested to see, to translate it into a clinical study later on. And so far, the combination of buprenorphine, naloxone plus naltrexone may be a good option to treat cocaine dependence in patients detoxified from opiates. And thank you for your attention.